All right, so let's just do a quick video on the final video, because we won't beat a dead horse anymore, on the treatment of gonorrhea. So as we start, I would encourage you that we build a structure, because look at all this bad chaos that's going on here right now. And out of some of that mess, we want to have some sort of structure so we can actually sort of think about this. So we're starting to attack this problem. Let's take the first thing out of this mess, which is going to be the treatment of gonorrhea, of course, what it's about. And then if I've got to look at all this stuff and sort of figure out where I would want to make my first branch of adding my structure, I sort of like to start with big, large things. And in this case, I'm going to break it down between one group where no proof of cure is needed, and then the other group where proof of cure is needed. So if we look at this, we all know from the reading that the CDC decides that what they like to do is basically give a one-time treatment inside the clinic because they believe that their patients are not reliable for follow-up, which again really doesn't apply to ours. And so their testing strategy is designed to ensure that no follow-up is necessary. So if we had to guess about this, right, anything that follows the CDC strategy is likely the one where no proof of cure is needed. So let's pull these suckers over here so we know that if no proof of cure is needed, it is most likely what we've come to know and love, which is going to be 250 milligrams intramuscularly of ceftriaxone and a single gram of azithromycin orally. And the beauty of that, according to the CDC, is that it can be done right in front of you. In other words, if they leave, they should be cured, hopefully. Keep in mind, this is not or, this is and. You have to give ceftriaxone and azithromycin. Let's look at if the proof of cure is needed. Well, in that case, it's going to be something the CDC doesn't recommend, but something we can probably find in UpToDate anyway. So let's break that down over here. It's probably going to be 2 grams of azithromycin, right? Or the dreaded azithromycin and gemafloxacin, which of course is not available in the United States. But nonetheless, it's an UpToDate. So let's break it down to our second tree before we analyze it. We're now going to get into the third branch of how to address this issue. All right, so let's think about this for a second. All right, this is going to be a CDC recommendation over here. And this is going to be the issues, whoops, let's try this. The issues associated with the Zithromax. And let's just talk about our way to address that. We're actually 4 layers deep right now, but you know what, I'll take it. All right, so let's go. We're at 1, 2, 3. And we're now going, okay. All right, so let's go and start from the beginning, and then we'll work our way over here. All right, so if we are looking at gonorrhea treatment, break it down to 2 big buckets. One bucket in which we don't need proof of cure, and the second in which we need proof of cure. And then we're going to look at those 2 treatment modalities, which would be, in this case, ceftriaxone and azithromycin. And that should be done in front of you. It's 250 grams of ceftriaxone IM and 1 gram of azithromycin PO. Keep in mind, the CDC recommends that regardless of whether or not there's chlamydia, as a co-infection, you need to treat both of them. And there's all sorts of reasons with that that has to do with increasing gonorrheal resistance. But all you really need to know is that in this case, if you don't need proof of cure, if you don't want them coming back or they can't come back to pee in a cup in about 14 days, it's going to be azithromycin and ceftriaxone given inside convenient care. All right, now let's address this side of the decision tree. This is straightforward. If they're unreliable for follow-up, or we don't want to test them, or we'd have to worry about it, then 2 grams of ceftriaxone, 250 milligrams of ceftriaxone IM, and 1 gram of azithromycin orally. Let's go to this branch over here. In this case, we're going to need to have them come back in 14 days to ensure proof of cure. During that period of time, they should be abstaining from let's just say they're zest for life until we prove that they're not going to be passing around gonorrhea to their friends and other people that may share a zest for life. All right, so if we're going to move down this thing, let's take a look at, first off, azithromycin and azithromycin plus gemafloxacin. So gemafloxacin and azithromycin, we're not even going to discuss it because it's not available in the United States. Which means our only option right now is 2 grams of Zithromax. So big point, if you can't follow up with them, right, and you don't want to go down this pathway, you are going to need proof of cure in 14 days. So 2 grams of Zithromax is actually a great deal. They can do it in front of you, or I suppose you could write a script for it, either way. All right, so no azithromycin, gemafloxacin, which means this right now is the only game in town. Now, this is actually not recommended, and why do you think that is? Well, surprisingly, it has nothing to do with the efficacy of it. It's got to do with concerns about monotherapy and possible increase in resistance, but nonetheless, this treatment is about 99% effective, especially if they do it in front of you. Again, CDC word is their patients are not reliable. So why would they not recommend this? And the answer is that it tends to cause nausea, upset stomach, and GI symptoms in up to 33% of the cases. Now, the problem is we don't really have an idea of how highly that's quantified, right? You know, everyone here has been nauseous, everyone here has had an upset stomach, and everyone here has had GI symptoms. So how would we address and mitigate the fact that this actually helpful treatment is not recommended because of these symptoms? All right, so let's figure out how to address the fact that this treatment modality, which is actually pretty good at like 99% or just slightly less, is somehow frowned upon by the powers that be, even though the effectiveness is pretty good. Well, the answer is it because it causes nausea, upset stomach, and GI symptoms, but of course, they don't quantify that. It's about 35%, but they don't quantify the intensity of the symptoms. Let's get rid of that. So how can we make this go away? And this applies to almost any oral medication that people don't tolerate really well. Well, we got a couple options. Right? The first is, believe it or not, you can actually ignore it. It is reasonable to do that. Though in this case, I wouldn't recommend it, but if you say, hey, listen, buck up, cowgirl up, you're going to be a little nauseous, right? You're not going to vomit. Take this, right? If it's going to hurt a whole bunch less than right now the urethritis you have going on or the cervicitis. So that would be one option. It's a reasonable option, but again, would not recommend it. All right. The second option would be to say, hey, instead of chugging down the 2 grams at once, right, which is probably what's going to be causing your GI upset, what you can do is you can say, hey, you got to take 500 milligrams, right, 1 hour apart for a total of 4, which gives you 2 grams. Because keep in mind that the nausea and vomiting is likely secondary to actually a large load of antibiotics in the stomach. In this way, you're good to go. It's over 4 hours. Zithromax has such an amazingly long half-life. I can't imagine there's an issue with all of that. And they're going to be more compliant because they're not going to vomit. The last and final thing you can do is to add Zofran to the mix. And Zofran works particularly well. You simply just write for Zofran, the normal sort of dose, and you have them take it 1 to 2 tablets about, let's say, 30 minutes prior to taking the Zithromax. And in this case, what this will do is they take the Zofran, they wait about 30 minutes, and then they take the first dose of azithromycin, then they wait an hour, and they take their second dose, wait another hour, they take the third dose, and then their fourth dose. So as an aside, this combination of Zofran for any medication that's not tolerated, as far as GI upset goes, you combine Zofran with Carafate during that course of treatment, works remarkably well. The Carafate lines the inside of the stomach, the Zofran controls the nausea, and when people say they can't take something because it upsets their stomach, you can try this combination, and when they try it and they don't actually get nauseous, you look like a rock star. All right, to wrap this up, first thing we did was ask our question about gonorrhea treatment. Then we built a structure 1, 2, 3 levels deep. We divided it into our first big buckets, which is, I'm going to look and divide this up into 2 groups. The group in which no proof of cure is needed, and the group in which a proof of cure is needed. Then I go down to my second level. I know that there's really only one treatment plan in which no proof of cure is needed, and that would be the one by the CDC, which is going to be 250 milligrams of ceftriaxone, a gram of azithromycin, and it'd be the big operative. And then the key point over here is, regardless of chlamydial co-infection, you should treat with both. And that's got to do with sort of obscure things. If you really wanted to, even though it's not recommended, it would be reasonable in this case, if somebody said they can't tolerate azithromycin, would be to actually put them on doxycycline. But that's not what the CDC recommends, but it's reasonable to do. All right. The second thing we looked at is that if proof of cure is needed, right, we can look at the second line treatment, which is azithromycin, gemafloxacin, which is not, we don't even have that stuff. I don't know why it's in up to date, because I'm just taking a very American-centric point. All right. However, Zithromax, or azithromycin 2 grams PO, actually has a 99% cure rate. It's really quite remarkable, maybe 98. Anyway, the only issue with that is it causes nausea and upsets. So what we do is we can actually use the sort of treatment plan that we've done before for things where people don't tolerate medications. The first thing we could do is ignore it and tell them, hey, listen, the benefits far outweigh the risks. Go have some ginger ale, you know, you're going to get a little nauseous, buck it up there. Right? The second thing you can do is you can actually spread out the dose. In this case, you can do it because azithromycin has such incredibly long half-life. Z-Pak is really a drug of compliance, and the idea is you take it over 4 days. They actually had a Zithromax chug once where you would chug some outrageous amount in a single day. It never really caught on, but it was great marketing. So you can spread that out. You could ignore it, right? Or you could add Zofran. Right. The beauty of Zofran is that if they really won't have much symptoms, if you take the 500 milligrams, make it every hour times 4 for the next 4 hours, and you load them up with Zofran prior to them actually taking it. So you ask the question, what do we do with people that are actually allergic to penicillin and have a penicillin allergy? And that is going to be for the next lecture. Again, thanks so much for watching these videos. If you have any questions, please feel free to reach out, and I'll be happy to answer them as best I can.